Hey, Jordan, can you hear us okay?
Or like little bunnies in the yard, like in the cave.
Our stream.
Doug, quick mic check. Looks like we don't have a quorum yet.
Can you hear me okay?
Yep.
I think Lynn is kind of on duty to make sure we end up with a quorum. Um, let's give it a couple more minutes, and we received confirmation from everyone that they're going to make it, or they have a representative coming. So let's just give them another minute or two.
Okay.
Thanks so much. Appreciate it.
Good morning, Lori. We do have enough for a quorum now.
Thank you, Len. We'll go ahead and get started then, everybody. Thank you so much and welcome to the Arizona State Board of Pharmacy uh, uh, Pharmacy Controlled Substances Prescription Monitoring Task Force. My name is Lori Walmsley and the date is September 9th, 2025. The time is 9:01 and I'll call the meeting to order. Doug, are you taking roll call?
I could do that. Lori Walmsley. I see you.
Present.
Amanda Sheenson. April Romero from the dental board. And Lynn, help me if you see anybody that in the meeting that maybe are having mic problems.
Will do.
Thanks so much. Dr. Thompson,
I'm here.
thank you, sir. Matthew Helms. Anybody from the Arizona Osteopathic Medical Association?
Matt just joined.
Thank you. Justin Bohal.
Present.
Hi, Justin. Jamie Von Glon.
Present.
Lynette Wingert or anybody from DEA?
Present.
Hi, Bethany. Sterling Struckmeyer.
Good morning, Doug. Good morning, everyone.
Good morning, Sterling. Raquel Rivera. Anybody from the medical board? Sarah Steffen.
I'm here. Thank you.
Good morning.
Good morning.
Teresa Manygoats.
Hi, present.
Susie Berman. Anybody from Access?
Susie is in the meeting on her phone.
Okay. Thank you. Vicky Bukta.
Present.
Hi. And I know Melissa Cotrese was trying to be here from Contexture. I think she was sending somebody else. Anybody representing Contexture? Davina was substituted out for Teresa. Yeah.
Yes, I'm here also.
Okay. Hi,
Mhm.
Davina.
Hi.
All right. So, Lynn, we have a quorum.
We have a quorum.
Thank you, sir. I think maybe first I'll let Miss Walmsley introduce herself a little bit. As our chair, and then I'll introduce the team I have up here, and that's my team, and then we'll start diving in if that's okay.
Sounds good, Doug. Thank you very much. I'm Lori Walmsley. I'm the current chair of the Arizona Board of Pharmacy, and it's our pleasure to host this group. This is our annual meeting that we hold in compliance with the state statutes to collaborate with all of the other medical professionals. Doug, if you want to go ahead and introduce your team. I don't think we need to do conflicts of interest today because I think we're all representing our individual boards and associations, but do we need to put that on the record?
I don't think it hurts.
Does anybody have any conflicts they would like to disclose? All right, Doug, why don't you go ahead with your team?
Awesome. Thanks so much. Again, I'm Doug Scavarla. I'm the director of the CSPMP. You guys, many of you have been to a lot of these meetings year over year, and you probably get tired of hearing my voice. So I brought an army with me today, and I'm going to let my team share a little bit about our work this year. To my left is Sam Hansen, and she's really my right hand woman. She helps with everything that from operations to I don't know if a lot of you know, but we run significantly on grant funding, and Sam helps manage some of that grant work too. And to Sam's left, we have Demi, and Demi, she spends a lot of her time helping answer a lot of the questions that come into our phone system and to our emails. And she's also who's responsible for getting users of the PMP registered. So keeps her pretty busy. And to Demi's left, we have Jake, and Jake is our data analyst. He's the one that crunches the numbers that often is used for compliance reports and materials that we put out to the public. On the other end that you don't see, I have Lynn Curtis. Lynn deals with our like public outreach and education. And Lynn, do you mind saying hello?
Sure. Hello. Hi there. I'm doing double duty today. I'll be also working on the Zoom meeting.
Thanks, Lynn. And finally, I have an epidemiologist that's part of our team, and her name's Merritt. And Merritt's gonna actually kick us off today. This year we did what we called our first annual CSPMP report, and I know I send a lot of materials and we post a lot on our website, but we wanted to put something really meaningful to the public together this year, and Merritt was instrumental in putting this together, and Jake too, and quite frankly everyone on my team. But I'm not going to steal any of Merritt's thunder. I'm going to turn it over to her, and she'll okay. Thank you. Sorry guys. Merritt is going to take over. So Merritt, please.
Thank you, Doug. Good morning, everyone. Like Doug said, my name is Maharat, and I'm the epidemiologist for the PMP. Today, I'll be sharing a summary of the 2024 PMP annual report. This is our first ever report, so we are very excited for people to review it, use it, and give us feedback that would help us improve our next annual report. While the full version is available on our website, this presentation will focus on the report structure, its purpose, and also key components. We created this report not just to document what we do, but also to make the data more useful to agencies across Arizona that are working towards the same goal as us. Let me share my screen. Okay. So just to give a little bit background on how we came up with doing this annual report, the idea for the report came from our everyday experience. We use the PMP data constantly in our work every day. And over time, we saw that other agencies like ADHS, local health departments, counties, and even universities were increasingly interested in accessing the same data. So by reviewing the different kinds of data requests that we receive, and also through our ongoing collaboration that we have with other agencies and attending meetings with them, we were able to identify the key metrics that could be valuable statewide in all organizations in Arizona. So once we identified the core metrics, we focused on making the report not just like a document, but also make it user-friendly so it's interesting to read and gives you a good idea without going too in detail. So we began with a clear definition to ensure transparency. I'm hoping everyone can see my screen. So this is the start of the report. So we started with a clear definition, again, to ensure transparency, especially around terms that may be interpreted differently by different groups. And also we have some terms that we use just within our PMP work, so it might be new for others. So it was very important to make sure that we define them so that the readers understand what they're reading. Again, then we incorporated visualization and interactive elements to make the report easier to navigate and understand. For example, in here, if you hover over the graph, you get to see what year you selected, but also what the prescription count was. So it was important to add those additional tooltips for the readers. So again, the goal was to create a tool and not just a document. Then next, we go to the body of the report. It begins with a high level look at the overall dispensation trends across all controlled substance. As you can see here, we are looking at 2019 to 2024. We also do comparison between those 2 years, 2019, 2024, but also the previous year, which is the 2023 compared to 2024. Then we break it down further by drug type, especially focusing on substances where we saw notable trends and patterns. The section helps explain the data before diving into specifics. The next part would be our, again, like I said, we break it down by different drug types. Just for the sake of time, I'm gonna pass a little bit. And then the next section of the report goes into our demographic and geographic analysis. And since many of our partners in public health focus on patient population and community level trends, we included a section on demographics and geography. This lets the local agencies or counties see how their counties are doing compared to the neighboring areas in terms of controlled substance dispensation, and it also provides a valuable context when it comes to help guide their local intervention that they are working on. Next, the next section of the report goes into what we do in our day-to-day life in the PMP. So we wanted to share our work. So for this one, to make the report, we also included the matrix from our day-to-day operation. And then this was very important because not many see what we do in this report unless they're like licensing agencies we collaborate with. So it was very important to include this. And for example, we are sharing with how many states we share data in our utilization report, which looks at the search that prescribers and pharmacists do using our platforms, which are the Aware and Gateway system, and also the number of registration that we have. And the next is our mandatory, we have state indicators. This is mentioned on patient report, but this is also something that we track for our grant report as well. And lastly, we have our mandatory use compliance. This one is one of the measures that we do to measure non-compliant providers. And then lastly, the report kind of concludes with key takeaways. Again, this report is not just about numbers, it's about using the data to inform real-world decisions. So for the key takeaways, it was important to include it, just understanding that not everyone have time to go over the whole report, but also this helps for users to read it and go to the section that they're interested in or relates to their work, and go to the section and read the report better. Again, for the sake of time, I'll close by quickly sharing a few highlights that we found from this report. And these are just a few examples of the kinds of insight you'll find, but we encourage everyone to explore the full report if you have the time, and also reach out if you have questions, but also ideas for future improvements that will be very helpful. Just to highlight some, I'll start from the top. Our main analysis that we looked at, as you can see here, looking at the controlled substance dispensation, overall dispensation has been going down, but we saw a little bit increase in 2024. Then we start kind of breaking down what could be that increase coming from. And in here, we are breaking those counts by different types. In this case, we're looking at opioid, benzo, and stimulants. The first one, the blue one, is showing opioids. As you can see, it's been going down until 2023, but we see a little bit rise in 2024. For benzos, there's a very sharp increase when it comes to benzo dispensation in 2024. So that was very interesting to look at and identify. For stimulants, we have been seeing increasing, so that was not a big surprise. So the next one that we were interested was the benzo. Why was that a sharp increase? So we start breaking down that into further looking at where those dispensations are coming from. And looking at that, we broke it down by in-state and out-of-state prescribers. And as you can see, most of the prescription that increase is coming from out-of-state prescribers. And what this is telling us from our research is that it's mainly due to the increase in telehealth medication, but also getting cross-state care that's been going on. So there could be more reason to that, but those are just some things that we found could be the reason. Next, jumping into, again, one thing I want to mention, we have also seen an increase in buprenorphine. This was expected, especially because of how now everyone can prescribe buprenorphine and it's available for everyone. It was important to see that the law change has really impacted the prescription somehow. Next is our demographic and geographic section. Again, when it comes to demographic for our dispensation data, we only have age group and gender. So that's what we looked at. Looking at the age group, the highest prescription was among adults 65 to 74. Again, that was not surprising just because we have been tracking it. When it comes to buprenorphine, we saw an increase in the age group 25 to 44. Again, we believe this suggests a better access when it comes to treatment. And also, one thing we were surprised and really found interesting was that we saw an increase in opioid, benzo, and stimulant prescription for the age group 1 to 4. Again, because we only have prescription data, we can't say more on that, but it's interesting to investigate further with in combination to other data types just to identify why we're seeing that increase. Next, looking at the geographic distribution, Yavapai and Gila counties have higher prescription rates. Again, this map is also interactive. You get to see the county name, the population size, the prescription count, but also it's looking at the rate because rate is not equals to overall count. So using rate was very important for us when we look at the patient counts. When it comes to, again, a higher rate, we saw a higher rate in Yavapai and Gila counties and a lower rate of prescription in Santa Cruz and Greenlee. Looking at, again, stimulants by county, we saw high stimulants in Maricopa and Pima County. We believe with research, this could be due to behavioral health access and also large university population that we have around that area. The next one was buprenorphine. Again, we saw a high buprenorphine prescription in Yavapai, Pima, and Navajo County, but lower in Yuma County. And again, we believe it could be due to the treatment gaps we have in terms of the prescribers they have in that county. That would be my end of my presentation. Again, it's very interesting, very helpful, very insightful. So, explore when you have the time, but also please let us know if you have any feedback. It would be very important for us. Before I close, any question?
I have one question. I'm an epidemiologist, so I'm really interested in data. For the data sources that you're getting data from for these maps and for the figures,
Yes.
are those, I know you mentioned something about them coming from pharmacies that use a specific system. So I'm just curious, what percent of pharmacies are actually utilizing the system in Arizona? Just to get an idea of, the reach of the data.
Yeah, so when I say system, we have we have two systems for us for PMP. We have a WHERE system where prescribers and pharmacists can register, are actually required to register so they can look at the patient report before prescribing or before dispensing the medication. So that's one. The other one is through Gateway. So based on the system that the pharmacy or the EHR use, those are the two systems they could actually use to track the patient report. Is that's
So it's-
specifically just for when it comes to registration?
So essentially, all pharmacies have to use one of those systems to dispense medications. Is that correct? Is that
I would defer this to Sam or Doug, but yes, it could be different. But at the end of the day, they would have like a specific system that would reach out to our system at the end.
I think I'll try to help a little bit on this one. And, what Mara just explained is the different ways that a practitioner or pharmacist can use the CSPMP to query it. And that would be through Gateway or the Aware system. I think the question was more about the data coming in, and the data comes in by pharmacies reporting to the PMP every single day. So that's law that the pharmacies have to report in daily. So all pharmacies are doing that because we monitor that compliance, and you'll hear a little bit more about that piece as we go through the meeting. But did I maybe answer the question for you?
Yes, thank you. I'm just wondering, if all pharmacies have to do that, but yeah, that makes sense. Thank you.
They do. How about anything else for Mara?
I have a question, Doug. This is Teresa.
Hi.
Sorry about that. I was wondering, you talked about the medications being dispensed, and I'm wondering through those systems that you just talked about, are they capturing the payer on the back end?
Payer is a field that is captured. It is not really monitored by us. We don't have a good way to monitor payers.
Okay.
And why this gets really confusing is almost every payer, when they submit data, they submit when they submit for payment, they use a bin number and they use an ID number, and when you submit that data, that data doesn't necessarily trigger if that's a private insurance, if it's Medicaid, Medicare. It's not perfect. So the answer to your question is yes, payers are captured. How accurate they are is questionable.
Okay. Yeah, I was just wondering, here at the department, we put out some reports too with regard to payer. So, and then some of the information you have in this report also would be interesting just to kind of, I know it's not apples to apples, but just to see what your system is putting out as metrics versus what we're seeing on our end at the health department. Thanks, Doug.
That, and Teresa, your team does have access to the data, so they could dive into that and do like a crosswalk for you. I don't know what to tell you to expect, but no, and Jake's suggesting to me that you can even do a data request with us, and if you can furnish us some data to crosswalk with,
Um,
Jake can work on that too.
okay, perfect. Thank you. Appreciate it.
You are welcome.
Merritt, thank you for the report. Is there any other questions or comments from the group?
I think the only thing I'd like to add is, how to get to this report. I know that our task force members received materials. Hopefully you were able to look at them before this meeting. And we gave you a nice, easy, quick link to get to this report. But if you were looking for it, if you were at the Board of Pharmacy website, you can click the CSPMP icon. And then from there, if you scroll down a little bit, we have a latest update section on our PMP website, and it says Arizona CSPMP annual report. So if you were wanting to look for that, if you're from the public just listening in, that's how you get to this report, and it's available to anybody. All right. Well, if we have no other questions for Merritt, we'll just kind of move along to our next section. And our next section is around our education and outreach. But before I do that, I know we had a few additional people that may have joined late. I just want to make sure I capture everybody that has made it to the meeting. April Romero, you made it to this meeting, correct?
Yes, I'm here.
Thank you. And Raquel Rivera.
Yes, I'm here. Hi, everybody.
Okay. Thank you. And I'm sorry I have to do this, guys. Just we have to follow public meeting law, so I just want to capture everybody that did make it. So thank you. And did Amanda Scheinson make it? How about anybody from the DEA? Okay, Bethany, that's right. Okay. And contexture. Okay. Thanks, guys. Lynn, I'm turning it over to you.
Thank you, Doug. It's going to be a difficult act to follow. Good job, Merritt. Again, my name is Lynn Curtis, and I'm going to be talking about the education and outreach that we've done this past year. Typically, what we do is we will highlight 2 or 3 very high-level, far-reaching educational efforts. But what I thought I would do this year is talk a little bit more about nuts and bolts, kind of how we get our information out, and give you some examples of how we do that and what it looks like and that type of stuff as well. And just very quickly, our evolution in our education and outreach really follows my path here on the team. I was hired late in 2018. And if everybody knows, that year was the year that then Governor Ducey signed the Opioid Epidemic Act into law. And so I was hired to really kind of take our educational efforts more into a technical direction. But because of that act and the way that we as public servants reacted to that, I spent a good portion of my first few years here just doing live presentations. And I really, really enjoyed that a lot, but I was very busy doing that. And people sometimes are a little bit surprised about the audiences that I would talk to. And so I'm just going to really quickly go through. I went through a lot of medical conferences. I missed the Mills and the Boondoggle, but that was a lot of fun. I've presented at teaching hospitals. I've also presented to the first year students, pharmacy students over here in U of A Phoenix. Government agencies as well, Access, ADHS. I've presented to teams in those entities. Licensing boards, although we do that now, but not quite as formal as I did in the past. And then also a lot of county coalitions. They were working very hard to get their medical providers registered in their counties, so I was out helping and supporting them as well. Also, law enforcement. I've talked multiple times to DEA. I've talked to the Attorney General's office and the team they have there. And then also, I used to be able to went down to HIDA, which is the high intensity drug trafficking area that Arizona is. And I would talk to beginning or new law enforcement. So I really enjoyed that a lot. but it really didn't get us any closer to really maximizing what we could do with technology. And of course, we know in 2022, that changed, right? And with COVID, we just changed how we do things. And that's why we're here today in our offices or homes, meeting. One of the things that I was able to do for the Board of Pharmacy is they put me in charge of getting Zoom up and running so we could use that for our board meetings and task force meetings, any of the public meetings that we have. So it was a really great opportunity for me, but it was also a great opportunity for me to transition our learning more into a technical aspect of that. And so instead of the meetings, we were doing webinars. And we started doing webinars quite a bit, and I still do webinars. But we had a really eye-opening lesson when we were offering a monthly webinar to our prescribers. Our Zoom account allows for 300 people to enter each Zoom meeting, and we would max that out each month. We were excited about that. Unfortunately, the reality is that our medical providers, whether they be pharmacists or prescribers, are very, very busy. To carve out an hour for lunch is very, very difficult for them. And so we were only getting about 30 or 40% attendance. And so we still do webinars, of course, but one of the things that I bring to the team is in the past, I've done some media production. And so we thought, let's take this material and let's put it in a video and make it available 24/7. And that's when we really started to reach more people and making it available. The Arizona State Board of Pharmacy has a YouTube channel, and that the CSPMP has their own playlist on that, and I've produced videos for our team and also for the Board of Pharmacy. But we did do that 40-minute prescriber presentation, and you can find it on our YouTube channel, and I've chaptered it out, so it's really very easy to get to. So that was a good step forward when it came to reaching people. Another tool that we use that's available 24/7 is our website. A couple of years ago, we looked at our old website and thought, we can do better than this. We worked on it. Jake did a lot of help. It helped me a lot with getting it up and running. And I believe we have a really good, easy website that's gets our users in and gets them where they need to be and the information that they need as well. One of the things that we do here at the CSPMP is if there's anything beyond the PMP that is impacting our users, we will try to communicate that as well. For about a year, anytime I was going out and doing live presentations, this was before COVID, of course. This was when the I was going to say ESPN, that's not that. The EPCS, Electronic Prescribing of Controlled Substances, where by statute you have to e-prescribe if it's a Schedule II opioid. When that project was trying to get up and running, I was going out and training on that as well. So on our website, you're not just going to find PMP material, but anything that has to do with controlled substances and anything that's on the horizon, any thing that we think that users might want to know. And so our website is a great way to communicate with people and available 24/7. So now what I'm going to do is I want to transition to some more tools that we have available, and I'm going to actually share my screen and talk about some of these. So Merritt mentioned the AWARE system. It's a platform that we use to register people and to also have folks access the patient utilization reports. And there's some other things on there as well. But one of the tools that we have is called the AWARE PMP announcement tool. And what I'm going to show you and what is in your material, there are links to these, is some of the different types of audience that we reach and some of the different types of announcements that we provide. The first one is it's a great way for us to talk to our users about what's going on with the tool itself. You can see a couple examples there. There are times it is technology where the technology will not work, and we got to let our users know that it's not going to be available. And so we get that out as well. The great thing about the Aware announcement tool is that we can send it to the emails that they registered with, our users, and we can also send it to a dashboard they have if they go into their Aware account. And so they're able to get it both ways. And we are somewhat judicious when it comes to using this tool because we don't want to, over communicate with our users, but it is very important. It's a very useful tool. Another good thing about this tool is that we can select who's going to be receiving these messages. And what I mean by that is we can send it to everybody who's registered with the PMP who has an account. We can also go down and we can select specific roles. So when you register for the Aware PMP account, you have to select a role. So this is a great way for us to really focus on people that need to hear the message. Just a little while ago, we had a major improvement to our Aware password verification, where now you can get a text message, and that is really improved our new registrants and them being able to very quickly validate their email. And this was sent out to everybody who has an account. There are times when, again, we have to send to select users. A couple of years ago, when we first started doing our usage compliance, we were noticing that there were quite a few users that had no lookups. And what we found out is a good portion of them were using a delegate to pull patient user reports for them, which is the way that you need to do it. But unfortunately, the delegate was not selecting the provider to get credit for that. So we jumped in, we sent these messages out. We have a dedicated delegate piece in our website. We also sent out a quick video. So we wanted to make sure that we got this taken care of, educated our delegate users. That way, their providers were not getting in trouble.
Hey, Lynn, can
Yes.
I just hop in there for one quick sec?
Absolutely.
With the delegate piece, it may have been delegates are allowed to help practitioners or pharmacists query the PMP. They're not required to be the route of querying the PMP. And I just wanted to make sure the task force, heard that. Delegates is a tool, a tool that you have in your tool belt to help. And I think what Lynn was talking about a little bit there is that if the delegate doesn't select the correct prescriber that they're working under at that time, that correct prescriber doesn't get the credit for the query of the PMP, which can create some compliance issues. So I just wanted to touch on that in case there was any confusion there. Sorry to interrupt.
No, you're fine, Doug. Thank you. Thank you very much. Another really useful way that we use this tool is just to remind our users that, that there are some statutes with usage and registration. I won't go on this very much right now, but it is a good way to remind them every so often. Another way that we can target users is by zip code. And we use this one of my other hats that I wear is I am the integration coordinator on the team. And so what I do is monthly, I'll send out this message to medical providers that are in select zip codes. And we've got it divvied up in 12 groups of zip codes. So hopefully our users will only receive this once a year. And so that's another way that we can kind of help make sure that we don't send this to too many people and target who we need. So what I just talked about was our Aware PMP announcements. It works really, really well. The limitation we have, though, is that we can only reach through that tool our registered users. And this group knows that there are providers out there that are not registered and not using the PMP. And so our next layer that we work with and that we provide educational material for is flyers. And we usually send these flyers to licensing boards, and we have begun to send these to the associations. And why this is important to us is that you are able to reach those people that are not registered with the PMP. So you are the final coverage, if you will, of folks that need to get this information. And I've got 4 that I'm just going to show you really, really quick. First, integration, we're always working on that. And let me just step back really quick. When I say integration, we talk about the Aware platform. That is web-based, and that's always available to our users. The Arizona State Board of Pharmacy actually has provided integration for all of our prescribers and dispensers in the state. And what that allows them to do is directly connect from their EHR or pharmacy dispensing software into the PMP to pull the patient utilization report. So it has a lot of advantages, and we've got a good amount of our medical folks are using it, but we still want to push that because it's just very, very easy to use. And when you click that button, you get credit for the lookup and you don't get in trouble with your licensing board. So that's what integration is. So we will send these out every now and then to different users. We specifically will send this type of flyer to, again, licensing boards and our associations. One of the other ways that we use flyers is to help specific users. One of my favorite things that I get to do every year is I train and help new residents, get registered for and use the PMP. And we work closely with their onboarding team. So what I do is in about March, I go in and look at this, I update this flyer, and then I send it to the onboarding teams with the learning hospitals throughout the state. It goes into the packet. And then I also have about an hour that I can talk to the residents and the new fellows about them being registered, because they have a unique registration that's a little bit difficult and it can be a little bit confusing. So we want to make sure that they're not confused and they get registered as quickly as possible. The other advantage that this program provides is that we get to talk to them about the PMP right when they start their career, which is a huge advantage. And so it's very, very good. And again, this is just specific information and a flyer that we send out to the learning hospitals. I bring this one up because this is kind of a fun one. We sent this to our associations a few months ago, maybe 5 or 6 months ago, asking them to maybe put this on their website or maybe include it into some of their communications. But it's a very high level reminder, fun way of reminding our users, that they've got to use the PMP. Integrations there, and it really does help them. And then also we've got state indicators on the patient utilization reports, which are typically, or were used to be called clinical alerts, that just helps them see things in the report that might be covered up if there's a report that has a lot of medications listed. So just a fun, creative way that we, again, try to get the word out. And then lastly, we share these types of flyers with our licensing board partners. They work really hard, and we can adjudicate only pharmacists and members that are our licensees that are under the Board of Pharmacy. So we do all we can. We provide reports. We provide this type of educational information that they can include when they contact their licensees that might not be completely compliant with statute. So that is the flyer bit. Stop sharing. And then really lastly, what I want to touch on is something that we have available to the public, and Demi takes care of this, and she does a wonderful job. It is our general email and our general voicemail. And it really is a good way for us to not only assist, but also to educate our users. But it's also a good way to find out if there's something that is maybe amiss, something that we need to look at a little closer. We're very good at answering those phone calls and those email messages. Demi and Sam do a really great job of taking care of that. So that is how we approach and how we get the word out to our users. Does anybody have any questions for me?
Lynn, I'd like to just maybe piggyback off what you said a little bit, and when we talk about having different messages for different roles, when you think of the roles that we have within the PMP, you could be a pharmacist, a prescriber, a law enforcement agent, you could be a delegate, and and not everybody wants the same message. And a great example of that is the way the law reads, the requirements to check the PMP is different for a pharmacist than a prescriber. So we don't want to feed prescribers information about what the pharmacist's responsibility is. It's only going to create confusion. When Lynn talked a little bit about the different roles receiving different messages, that's really what it's all about, trying to cater the right information to the right users of the PMP.
Thanks, Doug.
You bet. Lynn, thank you.
You're welcome. Thank you.
I'm very thankful for all that Lynn does, because Lynn wears a million different hats for us. He helps put on the production of our board meetings and this meeting. Like he says, we're doing double duty, but he's also really beating the bushes and trying to educate the best we can with a small team.
Thank you, Doug.
Again.
I think, Doug, if I may jump in, it's Cam Gandhi. Thanks, Lynn, for an awesome job that you're doing in communicating and trying to get people registered and using the PMP. I just want to throw something out about if there's something more we can do from a board of pharmacy perspective, or something you guys can assist us with to improve the registration utilization from your end. If you guys can maybe put your creative hats on and think of other ways that we can improve and move that metric, that would be really appreciated.
Will do, Cam. Absolutely noted. Will do. Any other questions?
All right. I think we can move along. Lynn, thanks. And I think we're going to jump into a little bit of discussion. And I think this is really what Kim was just, kind of looking for any idea from anybody here on compliance. And my team's going to talk a little bit about compliance, and myself too. And I'm going to turn it over to Demi.
Hi, my name is Demi Morales. I work as a regulatory compliance administrator. Kind of like how Doug and Lynn have mentioned, I handle all communication related to PMP compliance. such as delinquent data submitters, unregistered pharmacists, and outreach to the other licensing boards regarding prescriber noncompliance with mandatory use, statutes, and registration requirements. I'll just give a quick overview of some of our compliance efforts for this year. So for our pharmacist registration enforcement, the PMP conducts monthly pharmacy inspections that help identify pharmacists who are unregistered. From July 2024 and June 2025, 569 pharmacists have registered to us, or I'm sorry, to use the CSPMP. And then we have our CSPMP data submitter reporting enforcement. Any pharmacy with an active DEA number and active Arizona pharmacy permit is required to submit dispensations data daily to the CSPMP. Since June 2021, the CSPMP team has sent a total of 426 notices regarding delinquent reporting and opened 12 complaints. We continue to work closely with data submitters on a weekly basis to ensure compliance. And then we have our prescriber registration. Medical prescribers who hold a valid Arizona license and an active DEA number are required to be registered with the PMP. Since starting our notification process to the other boards in 2021, the CSPMP has successfully approved over 15,000 new prescriber registrations. The chart in your material packet on page 7 will show each board's number of unregistered prescribers between December 2021 through June of 2025. The difference in the number of unregistered prescribers and the changes in unregistered licensees throughout the years.
Thank you, Demi. Sam Hansen, I'm the assistant to our PMP director. I'm going to go over our prescriber usage for PMP. So every month, the PMP sends a list of 20 prescribers that we identify as non-compliant over to their licensing boards. And between July 2024 and June 2025, we've sent a total of 220 non-compliance reports to the other boards. I do want to point out we are right now going through a sunset audit, and that included the PMP processes and the entire Board of Pharmacy. It is possible after our audit is complete, the CSPMP may be sending more names in addition to the 20 that we are sending monthly to the other boards. Right there.
I told Sam to stop there because through time with the Auditor General, we engaged in many discussions with them, and we don't have our report back, so I don't know exactly what they're going to say. But part of the conversation was, why don't you send all names of non-compliance to the licensing boards? I explained to the Auditor General at that time that we've had this task force year over year, and we started measuring compliance as a result of decisions this task force has made. And we got to the point where we said that we would send a list of the top 20 non-compliant prescribers to the appropriate licensing boards. And that's kind of how this started. That's how we are here today. But I'm not really sure what else is going to be asked of me by the state. So I'll just kind of pause there. I would expect and hope for some dialogue here. But I need to be transparent with the conversations I've had. Dr. Gandhi?
Correct me if I'm wrong, Doug, but I think this is our second time we've run into this situation with the Auditor General. The first time was four plus years ago. We were asked to do something similar as well, and this is our second time. So whatever explanation we provided the first time was probably not good enough, and so we're back to the table talking about this.
Yeah, it's hard to say what's gonna surface in the report, but we were challenged 4 years ago to start measuring compliance, and that's how we got to where we're at today. I'm just concerned that maybe it is viewed as not enough. So if I could maybe ask for any input from the other licensing boards on, anything you want to share, what you like, what you don't like, the volume, how you navigate it, any of it, that would maybe be helpful.
Hey Doug, it's Raquel with the board. Thank you for giving me the opportunity, or for us the opportunity to speak. So the 10 has been reasonable for us to integrate into our investigations. We get a lot of complaints, us and the nursing board. And so the 10 is reasonable for us to wade through and still try to meet the 180-day time frame. I feel like any increase in that, we may see an increase in times and investigations, just depending on what the investigation uncovers. On our end, we are trying to find different ways on how to investigate compliance once we get the report. We'll pull a PMP, see if any specific patients need to be reviewed further. If it's their first time getting notified of non-compliance, that is mitigating for us. So we will try to push it through and see if an advisory letter is warranted, or if, during our investigation, we find out that it's a hospice provider or parts of an inpatient stay. We look at whether any other statutes were violated or whether it can be closed with no action. So I do think that if we're going to increase from 10 to 20 or higher, that may have an impact at the different licensing board levels for the timeframes for investigation.
Thanks so much for sharing that.
Hey, Raquel, it's Cam. The 10 that we forward to you, how long does it take for you to investigate and adjudicate those 10? Oh, you're on mute, Raquel.
I don't have that off the top of my head, but I can send you a sample of what that looks like. It really just depends on what happens in that case. Some of them can be closed quickly if we find out they're hospice and we confirm it. Others, if they're required to do a chart review and us pull like 4 or 5 patients, that can take around the 180 days, just depending on the findings.
I know that sometimes prescribers have more than one DEA number, and that can create some additional work for the other boards. We share the queries under each DEA number, but sometimes like a query under one DEA number doesn't carry over to your other DEA number, and that sometimes adds some burden. Like Raquel said, hospice has, if you're treating patients under hospice care, there's exemptions to check in the PMP, and we know that prescribers can self-report if they're hospice care providers. But that's not validated on our end, that the registration process is all done by the prescriber themselves, and it's under the honor system there. So that's a lot of words to say that I understand how what we send is not always is easy to work with and as perfect as it could be. And that's where I look for any feedback that other boards have for us. That Jake and Merritt, they can help weed things out for you the best they can through analytics, but I need your input, and Raquel, I think your comments were awesome. Thank you. How
Doug,
about
this is Teresa, Doug.
Hi, Teresa.
Hi, I'm wondering on this particular item, are there other practices that other states are using that we might want to take a look at? I mean, I haven't done like any research on what other states are doing, but could this be an option?
You know, I feel like Arizona is pretty progressive with what we're doing around compliance from a PMP standpoint. Um, you know, I go to conferences every year with my peers, and what we're doing is more than most PMPs around compliance.
Okay.
Um, so I'm open to any ideas that are out there, but I'm telling you, we're kind of out in the front.
Hey Doug, it's Bill Thompson. Sorry if I chat for a sec.
Yeah, I'd love to hear from you, Dr. Thompson.
I guess, and forgive me if I don't understand the whole process of how these things go out. I think your educational material that's in the packet is really good about the what you share with the licensing boards for the unlicensed or the unregistered prescribers. You know, perhaps more of an educational effort before it goes to the full investigative standpoint would help our medical board colleagues and maybe promote more compliance. And if you're already doing this, forgive me, in terms of when you detect someone who may not be registered, be it potentially a multiple DEA situation, any number of things, is it possible for a mailer to go out immediately to them, bypassing the official complaint process as a preliminary step? Then you might be able to reach more of these people who haven't registered and then reserve referral for investigation to those who, say, have received a letter and then on audit are still not registered.
You know, I think your comments are well thought out. The challenge we have is if you're not registered, I have no contact info for you in the first place. So I'm not the licensing board. You know, so all I can do is pass that on to the appropriate licensing board. What we have is we have a list of a DEA file, if you will, with all DEA numbers of prescribers, and then we crosswalk that with what is in the PMP system. And it's like, well, you have a DEA number, you have a license, but you have no PMP registration. So we know what DEA numbers those apply to, but I need the support of the other boards to connect with the end user because I don't have contact info. Was that helpful, Dr. Thompson?
It was. I just would hope that it would be easier with some of the crosswalking because, you know, there is a registered address for the DEA. You know, all the medical boards and nursing boards, I believe, require an active mailing, an accurate and true mailing address or some sort of contact information. And I don't know if in the age of tech, if there can be a way to just put those two together and automatically send a notice. I'm not trying to put a lot of tasks on, but I think that way, you know, as I say, the medical board can investigate, you know, the more serious ones, and then honestly a lot of these non-compliance ones, like I think the double DEA was something I talked about several years ago on this. I was probably inadvertently non-compliant because I had 3 DEAs depending on the institutions I was working at. So I think we can maybe make some ground and then keep the AG or the auditor general, yeah, happy and try and promote compliance.
Thanks for your thoughts.
Hey Doug, this is April.
April.
Um, so I do have a question about the non-compliance reports. As I understand it, you guys said you only send lists of 20 prescribers per month for each licensing board. How many, I guess, prescribers are, you know, being left behind, and how do you choose the 20 that you forward?
I think those are great questions, and because I've heard 20 per board, 20 total, 10 total. I'd like to clarify with the group. We picked the top 20 prescribers. And to April's question, it's the prescribers that have written the most prescriptions for control for a benzodiazepine or an opioid and had 0 queries of the PMP. So that list can change month to month. but that's what we're doing right now. So it's 20 total. That 20, it gets distributed to the appropriate boards, whatever board needs that information based on who populated the top 20 list. And again, the top 20 list, most prescriptions for an opioid are a benzo, because both of those have a requirement for a query of the PMP and 0 queries of the PMP. So yeah, my perspective is those prescribers, um, they had a lot of different chances to check the PMP. I mean, the numbers that we're talking about for this top 20, they've written at least 50 prescriptions for a benzodiazepine or an opioid, maybe more, and 0 queries of the PMP. So there is those one-offs, then those one-offs are hospice care. But the majority of these that are populating the top 20 list, they're just not using the PMP. I don't know how else to say it.
Okay, so if the Auditor General had their way, essentially you'd be sending reports for someone who even prescribes one prescription without doing a query.
I haven't received a report, but that wouldn't shock me.
Okay, and about how many, like you keep talking about the top 20, how many on average is this top 20 being pulled from? So like how many reports in total would, if you just started sending them all forward, how many reports in total are we talking?
Thousands.
Okay. Well, then, yeah, I absolutely would not be able to handle that.
Those are great questions, April. Thank you.
And then Doug, I just wanted to say, just maybe I could answer Dr. Thompson's question. So when the pharmacy board initially started sending out the 2 times a year, the list of unregistered prescribers, the board did send out a mailer to everybody on that list. We got a lot of returns. But another thing that kind of complicated it is sometimes they have an AZDEA, but they're not licensed in Arizona. They could be working at the VA or on federal land. So they're not really our licensee either at that point. So what we have done is, separate from sending out those mailers when we get the reports, and there's thousands of people on those reports sometimes, we put it in our newsletter. We provide the unregistered prescribers data that Jake pulls for me. We put that in our newsletter. We provide all the flyers that the PMP staff has created on our newsletter. But we have not taken action to date against somebody who's unregistered unless it comes up during an investigation. We have not taken action on these reports, but we have taken action on individuals who are reported to be non-compliant, and that violation is sustained with regard to clearing the PMP, not necessarily the unregistered part. So I just wanted to clarify that, Dr. Thompson. And if you have any ideas on how we can, minimize that number of unregistered prescribers, I'm all ears.
Thank you so much. Yeah, this is just the biggest challenge that we face. I think one thing that's going to work in our favor of getting increased compliance has been the transition in healthcare employment of physicians and providers from smaller individual group practices into larger practices that are more of an employed model with either healthcare systems, et cetera. And I think that, that hopefully can make targeted outreach better by addressing the heads of the big groups that are employing a lot of these providers and trying to work with them to make it a standard process, a standard part of the onboarding process with any clinician that comes into the state of Arizona. And I think, the right communication to those powers that be might help us move the needle a lot more in terms of overall registrants.
Thank you, Dr. Thompson.
One thing that probably could help us even do our work quicker and maybe as accurately as possible is we've talked about licensing board integrations, and I think Jake, I'm gonna let you let you share a little bit of what we have done with and maybe how it's helpful, if that's okay.
Sure, yeah. So with licensing board integration, if we receive a daily file of a licensing board's registrants, we can link that with our data, and then it could mitigate kind of some of those issues you were talking about where they have an Arizona DEA, they're an MD, but they're not an Arizona MD. We could use that to eliminate those people from that list. It helps get registration numbers up with our system, increases compliance, makes things go a lot smoother. So that is something we have been working on with the optometry board. We're receiving a file daily from them, and that part of the process is already complete. And with the osteo board, we are working on getting a file now. So that is something we would love to be able to set up with any board that is interested.
And
Thank
Jake,
you for that, Jake. And we are interested in that, so the medical board will be pursuing that shortly.
and when you say like a daily file, that's not like anything manual at all, right? Like the vendor for the other board is able to supply that.
Right, yeah, we would set up an extract either to go straight to Google Drive or to an SFTP.
Awesome. Thanks for that idea, Jake.
I think the last bit of compliance I had was since March of 2024, we've been holding quarterly meetings with other licensing boards. Attendance at these meetings has fluctuated, but we have had the medical and optometry board consistently attending. A main topic at these meetings has centered around the PMP's compliance process for measuring and mandatory use requirements. So I want to encourage all the licensing boards to please attend these quarterly meetings. They are open for, again, speaking about compliance processes, what maybe is working for your board, what's not working for your board. But if you also have questions just about any of your investigations that you're doing, feel free to bring all of your documents to those meetings. We can help you out. It's an open collaborative meeting. Again, it is quarterly. So we will send out an invite for the next one soon.
And for the licensing boards, I know some of you have come over or sent some of your team over and to kind of get some training one-on-one with my team on how to use the PMP, how to read it. You're welcome to ask for that anytime. Just reach out to me, John, Sam, doesn't matter. We'll set something up if that's helpful for your team, okay? Any other comments on that subject? Otherwise, I'm going to go into another piece of compliance that we haven't been able to move the needle with, and I wanted to make sure I talked about that too. And that's around there's the mandate for the prescribers to use the CSPMP, but there's also a mandate for pharmacists to use the CSPMP. And, whenever we're measuring prescribers, it's really easy for us because we talked about that DEA file, and that DEA file, every prescriber has a unique DEA number. Just some happen to have 2 or 3. Pharmacists don't have that. And when the data submitters, which again is the pharmacies dispensing every day, they're submitting this data. There's no requirement today for a pharmacist identifier to be reported to the CSPMP. So without a pharmacist identifier, we don't know who was responsible for checking the PMP. The world of pharmacy is vastly different than the prescribing world, where when you're in a pharmacy, you might be in there with 2, 3, 15 different pharmacists if you're at a mail order pharmacy. You could be working in different states. The challenges of measuring pharmacist compliance goes beyond just a pharmacist identifier, but we're not going to know how well we can measure compliance if we never have a pharmacist identifier reported to the CSPMP. Again, we talked about the audit. We're going through a sunset audit. During 4 years ago, we went through one. We were challenged to move the needle here, and we're still talking about it today. I really believe that we may be asked to do something like this. And in collecting a pharmacist identifier would mean that pharmacies would have to report maybe a license number, not maybe, a pharmacist license number to the CSPMP. That would enable us to measure compliance around all Arizona pharmacists. And we happen to know through our data that I think it's about 98, 99% of our prescriptions that are being filled in Arizona. 99% of the prescriptions reaching controlled substance prescriptions reaching Arizona residents are coming from Arizona pharmacists. So we would be able to measure 98, 99% of the pharmacists with a pharmacist identifier. I don't know if we'll be able to do it perfectly or not, but we would, it would be a starting spot for us. I guess a couple things that I would maybe want is, Jake, did I miss anything from explaining why we need it? Anything that you'd like to add? And then part two would be from a data submitter standpoint, Ms. Walmsley, maybe you'd have some comments too about that.
Yeah, I think you covered it well.
Okay. Thanks.
Yeah, Doug, I think your comments incorporate most of what we've talked about in prior task force meetings, and also with the board. The fact that the dispensing process varies so greatly between pharmacies and in various different systems too. I think it makes it a real challenge. I know other states have talked about this. I think Florida has been trying to figure out something kind of similar to this. I am not aware of any other state that has found a really reasonable solution for doing this yet. Can you comment on that?
I can. You're exactly right. There is no state measuring any meaningful compliance around pharmacist use of the PMP. There's states that are, doing things like having their compliance officer look at 5 prescriptions when they go into the pharmacy for an inspection. That is such a drop in the bucket. In Arizona, we're filling 7-8 million controlled substance prescriptions a year. To do 5 at a time is really not telling a story. So it's a challenge, and it's a challenge that I think I'll hear about again during our sunset audit.
Just a point of clarification too, Doug, this Cam. When you talk about controlled substances, you're really talking about Schedule II drugs, right? Because that's what the pharmacists are required to measure or check.
Yes, pharmacists are required Schedule II, and the prescribers are all benzodiazepines and opioids.
Yeah, and I think when you talk about, we can't measure pharmacists, but we do measure pharmacies. So we have some metrics of measurement. It's just not what the statute requires us. So if a pharmacy is not checking, we can deep dive into why that pharmacy is not checking and so forth. But statute requires us to measure pharmacists.
You're exactly right. We're proactively, it's really hard to do. Reactively, like from complaints or things like that, we're able to do a good deep dive into, did a pharmacist check the PMP? But proactively with, you know, the volume of prescriptions that are filled and no identifier to know what pharmacist was responsible. It's challenging. I think I bring this up because, you know, I expect to probably talk about this with our own board at some point throughout this year, and I wanted the task force to know that's going to happen. Any questions for me on that subject? I've talked about it every year for the past 4 or 5 years. And I think that we're probably going to try to, you know, talk to our board again and we'll see what we want to do. Okay. If no other comments on that, I am going to pass it on to Jake, and he's going to talk a little bit about ASAP standards. And just before he gets started, ASAP standards is like the format that data is submitted to the PMP. So we've been saying, hey, maybe we capture this identifier, or capture these different these other sources of data. When it gets submitted to us, it's submitted in what's called ASAP standards. And Jake's going to take it from here.
So yeah, like Doug was saying, we accept all of our dispensation data from pharmacies in what's called ASAP standards, the Arizona Society or American Society for Automation in Pharmacy. We upgraded to what is known as 4.2B in 2021, and the newest version, 5.0, is now available, and it's seeing some uptake throughout the country and through data vendors support. So we are looking to consider also making that upgrade. 5.0 adds a variety of new fields for potential reporting to the PMP. Some examples, PRE 11 through 15 are all fields regarding the prescriber address. Prior to ASAP 5.0, there were no fields for prescriber address. This is actually something that in statute is required to be reported to us, but it hasn't been able to as of yet. So we've been getting it from DEA data and things like that to supplement. It adds some additional options to existing fields, such as gender. It adds a non-binary and an X for unspecified, in addition to the typical FM for female, male, and U for unknown. We have additional product ID qualifiers to indicate cannabis. We've got some stuff that gives a little more information about the pharmacy that is dispensing, what type of pharmacy it is. It really helps with mail order, which we talked about kind of throughout this whole task force meeting. So it helps just modernize the reporting to the PMP. And it'll give us additional information to have the complete picture in the PMP, which will help prescribers and pharmacists make the best decisions when they do perform their lookups. Another one that I think will be very helpful are the alias names. So you can report a patient's preferred name as well as their legal name, so that when lookups are performed, they can be matched to both versions, more likely to find the correct patient, get the credit when you're doing a lookup, all that sort of stuff. And then if medical professionals have the most complete picture, it means that public safety is better because they can make the best decisions when they're prescribing controlled substances. We're looking to investigate this further and explore more towards the end of the year and into Q1 2026.
So I had Jake talk a little bit about ASAP standards because, you know, with a year often going by before our next meeting, and if you guys want more frequent meetings, we can do that. You know, I'll let the task force gauge, you know, what you're looking for, but I really just wanted to be on record saying, hey, ASAP standard 5.0 is out there. We recognize it's out there. We recognize that there could be some benefits from it. We haven't even started talking about this with our own board. Even if we started talking about with our own board, see what our board members think, it would require us to give pharmacies 6 months easy to be prepared to submit the data in ASAP standard 5.0 format. So this is very, very early stages of us just kind of making you aware it's out there. There are some benefits, and maybe one day we're going to move that direction, and just one day keep you in the loop. Guys, that's really all I had on my agenda this year. Maybe it'd be fair to say, is there something that we're not covering during this meeting that you wish we would? I want to make sure I'm adding value and that the task force is being heard for what you feel you need to be heard about. Well, I think I'll take silence as golden. So I think we covered what we're looking to do today. So I thank everyone. I'll let Lori close us out here.
Yeah, thank you everybody for your time and participation today.